Good morning, ladies and gentlemen. Welcome to the Basic HRM course. This is a course put forth by the Education and Training Committee of the American Foregut Society. And this is meant to be the beginner's course, so the nuts and bolts, the basics of high-resolution and high-resolution impedance manometry. We have a second course on Sunday, which is the advanced course, where we talk about how manometry and esophageal physiologic testing can be fit into workup of a symptomatic esophageal patient. We also have a little bit of pH and pH impedance at the end of this course. So one of the stipulations for organizing this course was that the course moderators had to have Rogers in their name. So we have the two Rogers for you this morning. So I'd like to introduce Ben Rogers from the University of Louisville and Roger Tatum from the University of Washington. And I'm going to hand over the podium to them in just a second. Just want to mention that masks are expected to be worn while attending all the sessions here, but the speakers can take their masks off while they speak. So Roger and Ben, podium is yours.
Thank you very much, Prakash. Greatly appreciate it. Thanks to everyone for attending this morning. I hope this is going to be a very good session. We have some great speakers for you, and my gratitude goes out to all of them for preparing the presentations for today and for being present. We do have a few virtual presentations today where our presenter will not actually be here in person. They will be on the discussions, however, that we're going to have just before the breaks in each session. So without further ado, I'm going to go ahead and introduce our first speaker, who probably needs no introduction, Dr. Peter Kyrillis from Northwestern University, professor of medicine in the Division of Gastroenterology, one of the founding fathers of the Chicago classification, if not the founding father of the Chicago classification, I would say, and my mentor, Peter Kyrillis.
Thanks, Raj. If I'm the father, then John Pandolfino is the son. And I think it's funny that I got invited to talk about the history of manometry. I think they're trying to tell me something, but anyway, I am a little old. So these are my financial disclosures. The only thing of interest here is really that we, in fact, patented the flip at Northwestern. So in the beginning, they wanted me to show you really the beginning of manometry. Well, that's it. The first recorded esophageal contraction in man in 1883, where they brilliantly showed that it contracts. And then the first demonstration of peristalsis in man in 1924. That's not all that long ago. And early on, it was kind of recognized that there was an art to manometry and that, yes, you have all of these contraptions, but it's an electronic chain, and you're basically recording a signal, and it's only as good as the weakest component in that chain. And that's true of all electronics, actually. So this was the first type of device that was invented. It was a syringe perfusion pump. So the water is in the pump, it mechanically pushes water in, you have a catheter going into the esophagus, the squeeze in the esophagus opposes that flow and it registers the pressure to the recorder. The syringe pump perfusion, and if you can do it with one, well then a better mousetrap, the pneumohydraulic perfusion pump. Who in this room ever used this device? All right, you're almost gone. There's just a few of us left. I know you did, Prakash. But this was a better mousetrap. So you have this chamber that you pressurize with compressed gas, and you go to basically 8 was the common number of external pressure transducers. This was, Arndorfer's name is attached to it all the time, but it was in fact invented by Jerry Dodds. He just let Ron make a living off of it. So Ron sold these things, and it was like a mousetrap that you had, a better mousetrap. And the graphic on the right there kind of shows the recording characteristics of syringe pumps as opposed to these pneumohydraulic pumps, which had a good enough frequency response for the esophagus. And this is, and then we got into other devices. And a key device in the development of manometry was the sleeve, the Dent sleeve, named after John Dent, who invented it. And you see a graphic of the sleeve that I actually used to do the first realistic recordings of the upper esophageal sphincter back in 1987. And you'll notice that there was a typo in that publication, which I discovered 19 years later. But anyway, what a sleeve device did was it would record the highest pressure along a length. And that's what you see on the right there. Whereas if you pull a catheter across, it hits the sweet spot and then it comes down again. You pull a sleeve across and it records the highest pressure in the sphincter for the entire length of the sleeve. So it was a way around sphincter movement. You had this 6 centimeter long recording surface, and if the sphincter moved up and down along that surface, you still detected the actual sphincter pressure. And this is the standard equipment of that era. We had polygraphs, so there were no computer recorders. You have that 8-channel pneumohydraulic pump there, and then you have a silicone catheter on the right with 7 side-hole recording sites and a sleeve sensor. This was the state of the art for probably 20 years. And this is what that manometry would look like. You have recording sites, you see the pressure peaks, and then you see the sleeve relaxation at the bottom. It was actually a very interesting way of recording esophageal pressures, and it was pretty accurate as far as LES relaxation was concerned. And then the world changed, and key to that change was Ray Klaus, who basically brought us into high-resolution manometry. Ray, I was a huge fan and a good friend of Ray's. He died prematurely some years ago, but this is kind of what Ray did, is he thought that, well, 8 might be good, but 36 is probably better. And then when you get all of that, you know, the whole concept of pressure topography came in, where you take all those line tracings and you transform them into pressure topography by interpolating between each recording site. And this is now familiar to everybody, but this was a huge revolution when this occurred, whatever it was now, 15 years ago. And the key innovation that revolutionized manometry was applying takt array nanotechnology to HRM devices. What you're looking at here is that mat that the lady is lying on actually has a multitude of pressure sensors in it, so it kind of detects all the pressure points on her body. And the technology that allows that to happen is shown on the right over there, where each of those little dots is independently detecting pressure, and they can be embedded onto these tiny little microchips. So basically, you have almost an infinite ability to record pressure in any level of detail that you need. And that's, this is the chain of high-resolution manometry, Sierra, Given, Covidian, Medtronic, and now it's Medtronic, of course. So you'll recognize the 36 sensor device there, and maybe you won't recognize the one that it was called high definition for a while, where you actually now have not only closely spaced sensors, but they preserve the circumferential pressure signature as well. So this is illustrative of that. This is a 3D HRM assembly, so you have your typical HRM sensor at the top there, where it does detect pressure in 12 different sectors, but it just averages them. Whereas the sensors there, the high definition ones, it detects pressures in 8 sectors and preserves them. So if you have a complex situation like this, where you have the EG junction and you have the lower esophageal sphincter sitting within the crural diaphragm, it's a very complex pressure environment, and it's not at all symmetrical. And in fact, if you look at how that records with a high-definition recorder, it looks like that little cylinder there where you have hot spots and cold spots, but very little symmetry. So take that, that's your high definition, and that's at one instant in time, and open it up so you can see the circumferential profile of the EG junction, and it looks like that. And it kind of makes sense when you look at what it was recording, because it is a highly asymmetrical thing, and most of the pressure in that area is in fact attributable to the crural diaphragm. So inspiration, expiration, you can see how the signature changes. It's quite obvious that the big blob there is in fact the apex of the crural diaphragm impinging on the esophagus. So this is the EGJ at rest and then during a deglutitive after contraction. During the after contraction, you're seeing the lower esophageal sphincter contract, and that's that circumferential band around. But take-home messages, most of what you're recording at the EG junction is in fact the crural diaphragm. And this is more or less another illustration of that, whereas you look at how a high-definition signature of a hiatal hernia appears. And here you see a segregated circumferential band and the crural diaphragm signature below it. So where are we now with respect to recording the EG junction? Well, Chicago Classification 4.0 is now live and in press, and in print, I should say. And we look at the EG junction as we look at two things. We look at the LES-CD separation, which is obviously very important. It's the definition of hiatus hernia. So here there's no separation. You have a superimposed crural diaphragm on the lower esophageal sphincter, and you compute the EGJ DCI below there, and it's the EGJ contractile integral is how it's computed. If you have some separation, as in this case over here, now the LES-CD separation is 2, and you still compute the EGJ-CI using the DCI tool below. And here is an obvious hiatal hernia where you have 4 centimeters separation. And now it's disputable as to whether you do your EGJ-CI to get both elements of the sphincter or segregate them apart, as you can do in that instance. So to summarize the history of manometry, basically first it was about temporal resolution, and that was the technology that evolved. Then it was about spatial resolution, and that's where we got into high resolution, closely spaced sensors, and finally it can be about radio pressure resolution, which is essential to understand asymmetric pressure zones such as the EGJ and the anorectal sphincter. Thank you.
Okay, up next we have Amit Patel, Associate Professor at Duke University School of Medicine and the Durham VA Medical Center.
All right, well, thank you to the organizers and AFS. My introductory talk will be on what does manometry measure and how is it done. So a brief outline, we'll discuss the whys and why nots of manometry, how to prepare the patient and the catheter for the manometry study, how esophageal pressures are assigned colors and transformed into the Klaus plots we saw in the last presentation, insertion and positioning of the catheter, and finally, several special considerations for the manometry study. In our recent ACG guideline on esophageal function testing, across the spectrum of esophageal symptoms, whether reflux suspected, obstructive, or atypical, high-resolution manometry can play a role. We'll hear about provocative maneuvers with the study in talks later this morning. So why do we do manometry? At its core, assessment of esophageal symptoms, particularly when they don't respond to anti-secretory therapy, and we can't explain them with alternate modalities like endoscopy or barium. In cases of suspected motor disorders, or cases where there's evidence of abnormal transit on these other studies. localization of the lower esophageal sphincter for placement of reflux catheters, and evaluation of esophageal motor function prior to pursuing foregut surgery. Relative and absolute contraindications to manometry can include obstruction of the esophagus, abnormal anatomy that precludes insertion of the catheter, cases of frank aspiration, although we can think about studies with dry swallows in that case, coagulopathy. If patients can't cooperate with the instructions for the study, swallowing on command obviously represents a contraindication. And finally, intolerance of the catheter. These are examples of high-resolution manometry catheters from different manufacturers. The key, as Dr. Kurylas explained in his talk, are the closely spaced sensors. So when we prepare patients for manometry, it's important to review prior diagnostics. Things like large hiatus hernias or high suspicion for achalasia spectrum disorders can be helpful for performing the study. Avoidance of medications that have the potential to impact the findings. These include a variety of medications, things like calcium channel blockers, nitrates, promotility agents, but importantly, opioids. And the decision to hold these medications for the study should be made on a case-by-case basis, taking into account the indication for the medication, the indication for the study, the clinical context, and the potential impacts that it can have on patient management. Assessment for the topical anesthesia used for the study, and importantly, patient education. A lot of our patients have anxiety around the procedure, and allaying some of that can be helpful. There's a lot of material on the internet, some better than others. There are nice videos on YouTube from Stanford and UCLA that we found helpful. So patients are typically made NPO for at least 4 to 6 hours prior to minimize the risk of aspiration. Apply the nasal anesthesia. And catheter insertion is typically performed with the patient sitting upright, facing the operator, drinking small sips of water through a straw to facilitate placement of the catheter. After the catheter is confirmed to be in place, patients are typically laid supine with a slight head of bed elevation for the study, and we'll hear about that protocol in the next talk. So at its core, as we just learned, manometry measures pressures. So when there's contraction from esophageal muscles, we see increases in pressure. And with manometry, these different pressures are assigned colors, and the idea is that warmer colors, our reds, our purples, are assigned higher pressures. And so when we have a high-resolution manometry catheter with all those nice closely spaced sensors, each of those is measuring these pressures that change with esophageal muscle contraction over time. These are assigned their colors. Software uses best fit data to interpolate and create these topographed plots that are named Klaus plots in honor of the late Ray Klaus. And so when we have the Klaus plots that we're also familiar with, on the y-axis is length along the esophagus from proximal to distal, and then time along the x-axis. The warmer pressures that we see at sphincters allow us to identify the upper and lower sphincters with ease. So in health, when we have excitation of esophageal muscles, leads to their contraction, leads to those warmer colors. In contrast, there's inhibition that allows for the sequencing of the contraction and relaxation of the lower esophageal sphincter. In contrast, in disease, we can have abnormal inhibition, and that can cause premature or spastic contraction, as well as exaggerated excitation, manifesting from stronger contraction and potentially abnormal relaxation of the lower esophageal sphincter. So we position the catheter, as we saw in the Klaus plot. We want at least one sensor in the pharynx, at least 3 in the stomach, and easy visualization of those 2 bands of pressure that represent the upper and lower esophageal sphincters. Identifying the diaphragmatic crura is important, and there's pressure inversion between the thoracic and abdominal cavities. If there's difficulty identifying that, having the patient take deep breaths can help magnify some of those changes. These are visually appealing patterns called butterfly images, but not a great thing clinically. In panel A, we have an example where the catheter is coiled in the lower esophagus in a patient with achalasia, and we see mirroring of that image above and below. In panel B, an example where the catheter is coiled in a hiatus hernia and moved retrograde through the lower esophageal sphincter. So it's incredibly important for the operator when they recognize these during studies to rectify the coiling. So that inability to traverse the lower esophageal sphincter manometry represents a critical imperfection. It's often seen in cases of achalasia spectrum disorders. So potential solutions for the operator can include having the patient stand up, raise their hands above their head, and take repeated gulps of water that may facilitate placement of the catheter, passage of the catheter. Counterclockwise twists on the catheter might be helpful. And then finally, placement under endoscopic guidance can be considered if we absolutely need that information clinically, and there's not alternate modalities that might be helpful in those cases. In contrast, an inability to traverse the diaphragm represents a non-critical imperfection and is often seen in cases of large hiatus hernias, as we saw in the prior image. So to end with a few special considerations for the study, thermal compensation. Because the catheter is calibrated prior to the procedure at room temperature, but the study is conducted and pressures are recorded at body temperature, there can be differences between reported and recorded pressures. So our solutions to this include intermittent calibration of the manometry catheter in a water bath that's at body temperature. Also, a thermal compensation maneuver after each study. After the study is performed, the catheter is extubated and held in midair. We can use the red study cursor to move over that period and use the software tool for setting thermal compensation to help address this discrepancy. Vascular artifact. We can have cardiac or vascular structures that impede our interpretation of the study, as we see here from the aortic arch. Asking the patient to tilt slightly to the left while supine for the study can help those structures fall away from the esophagus and allow for better interpretation of the study. And finally, sensor malfunction. As with any electronic equipment, manometry can be susceptible to malfunction. For sensor malfunction, if we have leaks that allow things like bodily fluids or cleansing solutions to get into the catheter assembly, that can result in one catheter recording unusual pressures that we don't expect. If this is a non-critical sensor, meaning not one over a sphincter, we can use the software tool to mask that channel, and the software will use data from adjacent channels to create best fit overlay. It's also important if there is a malfunctioning sensor to try to avoid having it over a sphincter, in which case it can really affect the validity of the study. So in summary, a few pearls. Manometry is useful across multiple facets of esophageal evaluation, not only for transit symptoms like dysphagia. Patient preparation for manometry should include an assessment for medications prior to the study to address whether or not they should be held prior to the study. These manometry sensors measure pressures with changes reflecting muscle contractions based on the assignment of colors. And we can see high tones that easily identify sphincters. The manometry catheter not traversing the sphincter is a critical imperfection, and it's incredibly important the operator address that at the time of the study, if at all possible. And finally, recognition of vascular artifact or sensor malfunction should be performed and addressed if at all possible. Thank you.
Thank you very much. So the next presentation actually comes to us virtually. This one is by Rina Yadlapati, who's an associate professor of clinical medicine in the Division of Gastroenterology and also the director of the Center for Esophageal Diseases at UC San Diego.
Well, hello, everybody. I really want to thank the AFS for not only inviting me to speak today, but giving us the ability to present to you virtually. I'm in San Diego. I'm not able to be at the live conference, but I hope everyone's having a wonderful AFS. And I'm going to spend the next 10 minutes talking to you all about how we recommend performing a manometry study. Now, many of you know that earlier this year, the Chicago classification update was published. It's version 4.0. And an important part of that update was the manometry protocol. And it's worth taking a glance back at the history of the Chicago classification to really appreciate why having a standard protocol is so important. Now, in the early 2000s, conventional line tracing manometry underwent a transformation really pioneered by the vision of Ray E. Klaus to high-resolution manometry plotted in esophageal pressure topography. And this was really revolutionary. But what experts in the field often liken the time to is the Tower of Babel story from Genesis, where many of you may know, God gave humankind different tongues and languages, which really impeded their ability to work together collaboratively and move forward. And similarly, in esophagology, what we saw with high-resolution manometry and this amazing technology is that different labs were employing different protocols, different interpretation schemes And so there was variation in diagnoses that patients would arrive at and what treatment they would receive. So in 2007, three individuals, John Pandolfino, Mark Fox, and Ariane Bredenord, convened and decided that they would develop an international HRM working group. And this is what led to the development of the Chicago classification, so that international labs could work together to arrive at a consensus on how we classify disorders, how we perform interpretation. So in 2015, the third version was published. And in 2019, we all came together, the International HRM Working Group, and there was consensus unanimously that we were in need for an update. So a version 4.0 was needed. And a key priority in that update was the need for a standardized protocol. Because up until now, there has not really been a recommended protocol. And that was clear when we surveyed the experts and we looked at 25 of the motility labs. Now, as expected, 100% of labs were utilizing supine wet swallows. Most of them were using the 10 supine wet swallows, where most of our normative data is derived from. 92% were utilizing a multiple rapid swallow. But thereafter, when we looked at the other provocative maneuvers and other positions, there was quite a bit of heterogeneity across the motility labs as to what was being utilized. So even amongst the experts, there was variation in the HRM protocol. So I'm going to dive right into now what is the recommended protocol. And this is a document that's available in the Chicago classification that goes through the step-by-step protocol. And very quickly, prior to the procedure, there is a recommendation that the patients are fasting for at least 4 hours and that informed consent is obtained. And a note that this protocol is recommended for a solid state HRM catheter system where the sensors are at least 2 centimeters or less spaced apart. But we recognize that labs may not have access to this configuration. And so the most important thing is that whatever system and catheter you're using, that the appropriate normative values are being used along with it. Now, in terms of the actual protocol, once the HRM catheter is transnasally placed, a very important part of the recommendation is that the protocol can begin in either a supine or an upright position. And this is really appreciating that labs do start in different positions, and we wanted to maintain that flexibility for the motility labs. But another very important part of the recommended protocol is that most of the time, patients should be studied in both a supine and an upright position, and we'll get to this a little bit later. Now, in our lab, our protocol is to start in the supine position, so the images I'll show you are in the supine, but again, this can be either supine or upright. Whichever that primary position is, it starts with a 60-second adaptation period, followed by 3 deep breaths. And this is really critical to confirming that the catheter has crossed the crural diaphragm and we're seeing these nice crural contractions and seeing a respiratory inversion point. And then a 30-second baseline phase. And during the baseline phase, we're able to appreciate our anatomic landmarks, the upper esophageal sphincter, and very importantly, the EGJ or esophagogastric junction complex. And in fact, in the Chicago classification, there was a working group that was dedicated to the EGJ complex. And some of the important recommendations for the EGJ complex are that it should be assessed during quiet respiration in the baseline recording, in a segment that's relatively devoid of swallowing and or recording artifacts. And here are examples of different EGJ complex configurations. And when you're assessing the space between the lower esophageal sphincter and the crural diaphragm, the recommendation is to score the distance between the center of the crural diaphragm and the lower esophageal sphincter during inspiration, if possible. Now, once you've assessed the baseline phase, we move into the actual wet swallows where we're able to assess LES relaxation and peristalsis. And these would be 10 5-milliliter wet swallows. Following this is the multiple rapid swallow. And some labs perform the MRS in the upright position, some perform it in the supine position. The optimal recommendation is that the MRS is performed in the supine position, and you can do the sequence up to 3 times. There will be a session later today specifically dedicated to the MRS, so I won't go into more detail about this. Now, once you've completed these steps, we change the patient's position. And in our lab's case, this now position changes to the upright. Again, you have your adaptation period and your baseline phase. And then there are 5 milliliter, 5 wet swallows. And this is really key in providing another assessment in a different position of both the EGJ and relaxation across the lower esophageal sphincter and also peristalsis. And specifically for EGJ outflow obstruction, we often will see discordance where the IRP is elevated in the supine position, but maybe not in the upright position. We also sometimes appreciate differences in achalasia and other motor disorders. And so again, corroborating in the upright position is, it can be very helpful. And then there is the rapid drink challenge. So another provocative maneuver, and this is of course performed in the upright position. You'll hear more about the rapid drink challenge a little bit later today. Now, if you go through this recommended protocol and you don't find a major motility disorder, but you had a high pretest probability that this patient has an obstructive physiology, you can consider solid test swallows, pharmacologic provocation. If you suspected rumination or belching, you can consider a postprandial high-resolution manometry with impedance. This is all up to what's available in your lab and who's performing the study. Also, if the results were equivocal or perhaps discordant, you might want to consider supportive testing, and this can be in the form of a barium esophagram that's timed and also with tablet, or a functional lumen imaging planimetry study. And we particularly will do this if there's a concern for EGJ outflow obstruction, or again, if there's discordant findings on the study. Now, this is a table that comes from the Chicago classification, and it really nicely reviews these supportive manometric measures. It details what the actual protocol is and what you would expect if there was a normal, healthy response. And there are some notes also about what an abnormal response might indicate. I do want to highlight that although this is the optimal recommended protocol, we understand that not every lab will be able to adhere to this protocol if there's limited resources or time. And also in certain scenarios, the entire protocol may not be absolutely necessary. So for instance, if you have a clear-cut type 1 or 2 achalasia from your primary position, you might not need to change that patient's position. If your patient is not tolerating the procedure or is at a high aspiration risk, you might not want to do your provocative maneuvers on that patient. And so these are things that are detailed in the Chicago classification document. And oftentimes people ask me, this protocol, it's very detailed and it seems time intensive. We've implemented this protocol as of a year and a half ago. And from start to finish, it typically takes 15 minutes. It's reasonably well tolerated by most patients. And so it has not added a significant amount of time or burden in our lab. But again, it's meant to be a flexible protocol that can be modified and optimized for your certain scenario. And this is my last slide, this is the hallmark figure from the Chicago classification. And it's a busy figure. There's a lot of arrows and boxes. But what it's really meant to do is incorporate in this new recommended protocol into this classification scheme of how we arrive at a diagnosis. And these boxes that are outlined in red highlight the protocol. So again, this protocol recommends starting with the 10 wet swallows in the primary position. If you've done that and you need to move on to step 2, that is looking at your swallows in the secondary position and also your provocative maneuvers with the multiple rapid swallow and rapid drink challenge. And finally, if there's no disorder of EGJ outflow or peristalsis, but you had a pretest suspicion of outflow obstruction or rumination, you may want to consider meal challenges based on what you were suspecting and the patient's symptoms. So once again, I want to thank the AFS for this opportunity. I hope you all have a wonderful AFS conference. Thank you.
Hello and welcome to the Motility Vision at the University of Louisville. My name is Ben Rogers. In today's video, we're going to discuss the basics of manometry, how to appropriately prepare a catheter for placement, techniques to use when the catheter has trouble passing the lower esophageal sphincter, and also how to carry out a procedure using currently accepted protocols. This is Amy. She's our Motility Center's lead nurse. She's going to be performing the procedure today. Amy represents the most vital part of the process, a technician well-trained in performing manometry studies. And here you'll see the supplies she's going to use. All patients should be NPO for at least 4 hours prior to the procedure. For today's procedure, we'll be using a solid-state high-resolution manometry catheter with sensors at 1 centimeter intervals. However, the process can be similarly attached to waterproof use systems. The first step is adequate lubrication and anesthetization of the nostril. This can be performed using either lidocaine jelly or by topically applying the lidocaine jelly with a Q-tip. The patient should be coached during the period to be ready to swallow as the catheter passes into the posterior oropharynx. If there's trouble, remember that you can always have the patient stand, raise their arms, apply a 45 to 90 degree twist on the catheter itself, or have the patient do repeated gulps of water. Following insertion of the manometry catheter, the patient should be allowed to get accustomed to the catheter for at least 1 minute. The procedure can begin with the patient either upright or supine. Our center starts with the patient lying down, and so that procedure is what we'll be demonstrating here. But provided the appropriate protocols are utilized and alterations to DCI and IRP in the upright position are considered, position at onset is left to physician preference. Appropriate identification of landmarks, including the LES, is undertaken here at the beginning of the study. Proper demarcation of the diaphragmatic crura is aided by having the patient take 3 large breaths. We aim to have at least 3 sensors in the stomach. Once correct positioning of the catheter has been confirmed, a baseline period of at least 30 seconds should be obtained. Following baseline acquisition, we begin with 10 supine swallows, each of 5 milliliters of water. You can see that Amy is marking these swallows as we go and ensuring that enough time, we typically allow 30 seconds, has passed before starting the next swallow. Patients will often have the urge to swallow, as I frequently do here in the video, and so appropriate timing is a key component. Here you can see us performing our first provocative maneuver, which is called multiple rapid swallows. At our center, we perform 3 sequences per each patient in order to allow additional evaluation in case some of the multiple rapid swallows fail. Again, as you will see on my own study here. Following this, we have the patient sit upright. Again, we have the patient take at least 3 deep breaths to confirm the catheter is still in the appropriate place. And we allow, again, a 30-second baseline period to let the patient become accustomed to the catheter in its new position. Subsequently, we perform 5 upright wet swallows, followed by our second provocative maneuver, which is part of the Chicago classification, called Rapid Drink Challenge. Please keep in mind that although we're not demonstrating it here, in individuals with high suspicion of a major motility disorder where none is found, additional testing including solid test swallows or a solid test mill should be considered. Further, in individuals where a rumination or belching disorder is suspected, please consider postprandial high-resolution impedance manometry.
Our next segment of this course today is going to explore the individual metrics that we use in the Chicago classification diagnosis. And so very appropriately, our next speaker is actually Dr. Ben Rogers, the person you just saw who was the victim in that particular video. By the way, it was a requirement of being a course chair that you had to have been subjected to manometry yourself in order to be a course chair, and I have as well. And also, he may have ineffective esophageal motility. I don't know if any of you guys caught that. But. So without further ado, Dr. Ben Rogers is an assistant professor of medicine in the Division of Gastroenterology at the University of Louisville. And yes, I did say that right. He and I are the only 2 people in the room who probably can say it right. Ben, please come on up.
He's selling himself short. He's had 3. Is that right? 5. And several pH impedance catheters as well, apparently. So, as you all know, my name is Ben Rogers. I don't have contraction reserve on multiple rapid swallows. So I'm going to start with the last slide of Rena's talk, And just reiterate that the first and most important step of high-resolution manometry assessment is the evaluation of the integrated relaxation pressure. And so integrated relaxation pressure, or IRP, is taken across the high pressure zone that's formed by the lower esophageal sphincter and, in healthy individuals, the crural diaphragm. So we have to make sure that this metric is always obtained following upper esophageal sphincter opening, and sometimes the software has a little bit of trouble with that, as you all know. It's found over a 10-second period after upper esophageal sphincter opening, and the window is automatically generated as demonstrated here. Now, you're not going to have the yellow box, and it depends on the software, but it will automatically generate the IRP for you. The period can be contiguous or non-contiguous, which is to say that the software will automatically also determine the 4 seconds with the lowest average composite score, and it will retain that for you. And we report this in millimeters of mercury. So some IRP considerations. Normal IRP values are going to vary by manufacturer and position. This was actually, this graph is taken from a normative study that many of you contributed to. It evaluated patients over 4 continents, actually. And we found that true to prior suspicion, Medtronic versus Labrie versus Diversitech were different, as demonstrated on the left, center, and right. And in the green, orange, and blue, you can see that the overall supine and upright positions do change the measurements as well. Please consider that even though your software can and probably will report mean values, it's median values that we use to determine IRP for the Chicago classification. And also please keep in mind that lower IRP thresholds may indicate obstruction where contractility is absent. This is one sentence, but this is actually a huge point in the evaluation of high-resolution manometry, which will be discussed later, I'm sure. So you can see here that there's no peristalsis in either of these swallows. This is from the same patient. This IRP is normal. Whereas later on in the same study, you can see that there's panesophageal pressurization, and with that amount of pressurization, the IRP is abnormal. Now, you can't appreciate that, but that was on the 2 left, that was 0 and 6, and then on the far right, that's a 20 millimeter of mercury IRP, so that's quite significant. And again, you can tell that I've tried to retain this is the actual read from that study, so this is something you'll encounter in real time. Also, please keep in mind that now this is something that Amit Patel touched on, but you have to consider the fact that IRP is referenced to gastric pressure, and this mostly comes up for me where there's a sensor out or something like that, but we always have to be aware of that. So we also must ensure that only the LES is captured, and this is something that I encounter very frequently. Again, this is taken from sort of a quote-unquote live study of mine that I had recently. You can see, hopefully, that the IRP is elevated here. That's 18.3. But when you adjust to just include the lower esophageal sphincter itself and not the crural diaphragm component, which you can see is below, the IRP normalizes. And this is actually something that again, is not infrequent in my own practice. And so they're going to talk about this much more, but just to briefly highlight, you can use the buttons on the right side of your screen to sort of make sure that that's what you're gathering here. So the distal contractile integral, or DCI, is a composite measurement of the amplitude, duration, and length. It's reported as millimeters of mercury per second per centimeter. And this is a good graphical representation of the way this is obtained. You can see on the right-hand column, the y-axis is length along the esophagus, the x-axis is time, and then you've got this sort of three-dimensional topographical representation where the warm colors, as they're often described, the reds and the yellows, are representing higher pressures, and the blue and green represent the warmer colors or lower pressures. And you can see the so-called Klaus plot here overlaid on top of this, and it sort of gives you an idea that, in essence, it's a two-dimensional representation of what is actually a three-dimensional metric. Keep in mind that the isobaric contour must exceed 20 millimeters of mercury. And you can adjust, again, this is something we're going to discuss in much greater detail, but you can adjust that on the, using buttons that are dependent to each software, but it's relatively straightforward in assessing this. So we want to make sure also that we include the portion from the transition zone to the proximal margin of the LES. You can see here that in this study, the DCI is a little low. The transition zone, that is from skeletal to smooth muscle, is probably higher, and you can actually see the second segment of smooth muscle here below that the horizontal arrow there. We want to make sure we include that. In this particular example, you can tell that it probably didn't make that much difference in an individual swallow level, but it certainly can occasionally. And so here you'll see the opposite, whereas on initial read, the software here measured the LES where I'm drawing the line, and that gave us a borderline sort of you take a second look value there versus if you can go ahead and correct this box and include the LES to include the after contraction there, you can see that you actually get a hypercontractile sequence. So we have to be careful about where we leave that as well. So distal latency. Distal latency is the interval between upper esophageal sphincter relaxation and the contractile deceleration point, which is actually the point between the proximal rapid and distal slow phase of esophageal contraction. And so what this actually represents physiologically is the conversion from the smooth muscle of the esophageal body to the LES after contraction area. So you can see here that this is the that sort of bend in the lines is the contractile deceleration point. That's where you want to make sure that you have your distal latency marked. So you can see here it's right here. The thing to consider actually is that in many of the swallows you have to make sure that the LES is appropriately recognized and that you move the CDP point down to within 3 centimeters of the lower esophageal sphincter to make sure you're getting the right measurement. I see this fairly often where there's a quote-unquote spastic contraction, and in reality it's just a movement of the CDP that will sort of normalize this, if you will. I see this one very frequently as well where there's a bit of a pressurization there, but the true CDP can be moved forward, and this will give you a more representative metric here. So peristaltic breaks, finally. So fragmented swallows are now labeled, as most of you know, ineffective swallows in the new Chicago classification. And the DCI has to be normal, that is to say greater than 450. And keep in mind that the breaks have to be greater than 5 centimeters. Again, the measurement of these will be discussed in greater detail, but it has to be at least 5 centimeters in order to be considered a significant enough peristaltic break. There's a tool that you guys will learn how to use, but you are going to essentially measure this gap between the full peristaltic sequence and the skeletal muscle there. And with that, I'll end my talk, actually. And I will also say that Joan Chen is going to be here later in the week, and she's not going to be joining us in person today, though. So Joan Chen is, can I borrow the thing? So Joan Chen is assistant professor at the Division of Gastroenterology and the director of esophageal motility at the University of Michigan.
Good morning, everyone. My name is Joan Chen. I'm from the University of Michigan. I'm sorry I can't be there with you today, but I would like to thank the American Foregut Society for inviting me to give a talk on classification of individual swallows according to the Chicago classification. Before we jump into detailed discussions on interpretation of swallows, I'd like to quickly review some basic requirements for including individual swallows into the analysis. These basic requirements are that the upper esophageal sphincter and the lower esophageal sphincter should be visible in the same window if possible. The diaphragm should be traversed by the catheter as typically indicated by the pressure inversion point. We also would like to ideally have 3 sensors in the stomach below the lower esophageal sphincter to measure the intragastric pressure. We would like to only include single swallows and not double or multiple swallows. And finally, each swallow should be spaced about 30 seconds apart to eliminate the effects of deglutitive inhibition. Swallow artifacts happen not infrequently. After all, patients are awake and in at least some degree of discomfort. Some of the more common swallow artifacts that should result in the swallow being rejected are dry swallows, double swallows, swallows less than 20 to 30 seconds apart, or swallows that are close to a belch, cough, or gag. And now we're ready to move on to looking at individual adequate swallows. For each included swallow, we will assess the swallow-induced EGJ relaxation and contractility in the body of the esophagus. Contraction strength or vigor, contraction pattern, and interbolus pressure pattern are assessed for each swallow. So as I mentioned, we will look for impaired esophagogastric junction relaxation first. These figures here are examples of abnormal esophagogastric junction relaxation. And you already know from the previous lecture that the integrated relaxation pressure, or IRP, is the HRM parameter to assess EGJ relaxation. In each of the examples here, the IRP is abnormally elevated. These are examples from patients with type 1 achalasia in the first figure, type 2 achalasia in the second figure, type 3 achalasia in the third, and EGJ outflow obstruction in the final figure. And now we move on to looking at esophageal body contractions, the contractile vigor, pattern, and intrabolus pressure. For contractile vigor, again, you already know that the parameter used in HRM to define contractile strength is the distal contractile integral, or DCI. And swallows with low contractile vigor or hypomotility, or also called ineffective swallows, are defined as failed if DCI is less than 100, weak if DCI is between 100 and 450, and fragmented if there is a peristaltic break of more than 5 centimeters at 20 millimeters of mercury isobaric contour. This requires a DCI of at least 450, however, for a swallow to be considered fragmented. Otherwise, it is considered a weak swallow. Here are HRM examples of hypocontractile swallows. In the first is a failed peristalsis with DCI of 0 and normal IRP. In the middle, this is a weak contraction with DCI of 206 and again normal IRP. The third is a fragmented swallow where the DCI is normal at 674 and there is a peristaltic break of 5.7 centimeters at the transition zone. So again, failed, weak, and fragmented swallows are all considered ineffective swallows based on the Chicago classification version 4.0. Now let's talk about hypercontractile swallows. A hypercontractile swallow is one that demonstrates a high DCI of greater than 8,000 millimeters of mercury times second times centimeter. There are variations to the contractile pattern under the umbrella of hypercontractile swallow. It can be seen as a single peak strong contraction, but not infrequently seen are these multi-peak contractions that was previously described as jackhammer contractions. However, the jackhammer pattern is not required for a hypercontractile swallow diagnosis and is just a variant of hypercontractile swallow. Another less frequently seen variant is one where hypercontraction is located in the lower esophageal sphincter, or it's also called LES-dependent hypercontractile swallow. In this example on the right-hand side, the DCI increased into the hypercontractile range only after the analysis box was adjusted to include the lower esophageal sphincter. When assessing esophageal body contractile pattern, we also look at the latency of deglutative inhibition to assess premature contractions. The HRM parameter for defining a premature swallow is distal latency, as you have already learned from the prior lecture. A distal latency of less than 4.5 seconds makes the swallow a premature or a spastic swallow. You can see this in the first figure up top, in comparison to a normal swallow with normal distal latency in the lower figure. Lastly, when evaluating individual swallows, we also look for patterns of pressurization. The patterns may be panesophageal, from the upper esophageal sphincter to lower esophageal sphincter, or increased intrabolus pressure from the esophageal contraction to the esophagogastric junction. These are some examples of pressurization pattern seen on individual swallows. Panesophageal pressurization is assessed at 30 millimeters of mercury isobaric contour, where uniformly increased pressure is seen from the UES to the LES. This can be seen in type 2 achalasia or in EGJ outflow obstruction. Increased intrabolus pressure is seen at 20 millimeters of mercury isobaric contour and can be seen in esophagogastric outflow obstruction or can indicate a subtle or latent obstruction in the right clinical setting. This concludes my presentation on how to interpret individual swallows on high-resolution manometry. I hope you have found this helpful. With the knowledge you now have on the HRM metrics and classification of individual swallows, we can now move on to using the Chicago classification version 4.0 algorithm to diagnose esophageal motility disorders. Thank you so much for your attention.
Okay, well, that brings us right to our next talk, actually, which is going to really pull the information from the last two talks together. So I'd like to introduce Dr. Abe Kahn, who's Associate Professor of Medicine and has been the Medical Director of the Center for Esophageal Health at NYU since 2016. Dr. Kahn?
Okay, thank you very much to AFS and the course organizers today for allowing me to speak. So as mentioned, my task was really to try to put this together and introduce you again to that hierarchical classification scheme of defining disorders based on this high-resolution manometry protocol. So just a friendly reminder, remember this really applies to patients with normal foregut anatomy in terms of the specific metrics without prior surgical or invasive foregut intervention and without large hernias or paraesophageal hernias. And endoscopic or radiographic evidence of obstruction really can preclude using some of the specific metrics of Chicago 4.0. And what we're going to go through today is really some of the updates from 3.0, which you've heard about already. And a lot of what we'll be talking about is what are conclusive disorders versus inconclusive patterns, an emphasis that specific motility disorders should be considered clinically relevant only in the context of specific symptoms or supportive testing. And what I'll be referring to also, and I encourage all of you, especially that are new to this, to really read some of these technical reviews that have come out this year associated with the Chicago 4.0 classification. So again, going back to our main classification scheme slide, it certainly can appear pretty intense, pretty ominous, but when you start going through it, it becomes much more manageable. And really becomes logical. So we're going to walk through this in terms of how to define disorders one at a time. So you've heard about this already. The first step is to really say, do you have an abnormal median IRP in your primary position? If you do, and you have 100% absent peristalsis, meaning all swallows are either failed or premature, you have achalasia. Now you might get there as well if in the second position, you've also done some swallows, and you still have that elevated IRP. And then depending on the pattern, you will have a certain subtype of achalasia. Now, this is from the images from the technical review of Chicago 4.0, representative type 1, 2, and 3 achalasia swallows. In type 1, you have 100% failed peristalsis without panesophageal pressurization. Typically, it appears like there on the bottom left, a lot of the swallows. Type 2, you start having this panesophageal pressurization above a specific millimeters of mercury in at least 20% of your swallows. And type 3, that's when you have premature swallows, at least 20%, where that distal latency is less than 4.5 seconds. And importantly, with the Chicago 4.0, you do not have any peristalsis overall. Now, you will end up in this situation, if you do a lot of this, where you end up with a diagnosis of inconclusive achalasia. And what does that really mean? Well, there's three main situations you're going to end up running into this inconclusive achalasia diagnosis. One is having absent contractility with a median IRP at the upper limit of normal in both positions, with or without that panosophageal pressurization. Or if you end up doing two positions and you end up seeing actually some peristalsis in one of those positions, that'll really take it away from being conclusive achalasia type 1 or type 2 in the primary position. And if you have abnormal IRP with some evidence of spasm and peristalsis, that would be inconclusive type 3 achalasia. And the confidence of whether or not you really have type 3 achalasia really can be increased if you have a higher percentage of premature swallows. And we'll get to EGJ outflow obstruction. But if you meet criteria at the same time for EGJ-00, you would classify that as EGJ-00 with spastic features, which may represent an achalasia variant of type 3. Now, I'm going to be referring to a lot of these clinical algorithms, which are paired in these technical reviews, and they're all out, at this point. So I encourage you to read these because not only does it go through what I just mentioned, for achalasia, and you'll see it goes through a lot of things with inconclusive disorders for the other disorders, it also tells you how to think about this in a practical context and even implies what you should do with treatment. So you see there on the left in your conclusive achalasia diagnoses, it talks about definitive treatment options for type 1, 2, and 3. And then if you have inconclusive diagnoses, it typically is going to request that you do a time barium esophagram or flip to really strengthen your diagnosis. Now, moving on, if you do not meet criteria for achalasia, but you do have an abnormal median IRP, how do you end up getting down to EGJ outflow obstruction, a much harder diagnosis to make than it was for Chicago 3.0? And one of the main highlights of 4.0 in this disorder is that a manometric diagnosis of EGJ outflow obstruction is always clinically inconclusive. And to actually make this a clinically relevant, conclusive diagnosis, you need several things. Not only do you now need a median IRP that's elevated in both positions, but you also need at least 20% of your swallows with an elevated intrabolus pressure. You see that little yellow box at the top image there on the right, and that intrabolus pressure should be above 20 millimeters of mercury, where you're really seeing some pressurization between the onset of the peristalsis and the EGJ. You also need evidence of some peristalsis, because otherwise you would have an achalasia pattern. And then you need clinically relevant symptoms of dysphagia and or non-cardiac chest pain. And finally, you actually do need another investigation supporting obstruction with a time barium esophagram, preferably with a tablet or a flip, panometry evaluation supporting EGJ outflow obstruction. Now, the authors of 4.0 also talked about inconclusive manometric diagnoses of EGJ-00, although I also told you that overall, it's always clinically inconclusive if you just have a manometric diagnosis without some of the other things with symptoms and esophagram or flip. But you might have this inconclusive diagnosis with an isolated elevated median IRP supine, upright, or having just supine intrabolus pressure. And you're going to hear about in the next few talks some of the additional considerations and how to really apply them in this diagnosis or potential diagnosis with the rapid drink challenge, solid food, and even pharmacologic provocation to support your manometric diagnosis of EGJ outflow obstruction. Now, it's also recommended you describe this outflow obstruction in the context of peristalsis. You can see the image down there on the bottom right, whether or not there are hypercontractile features, spastic features, ineffective motility, or no evidence of disordered peristalsis. Now, the authors actually of the subgroup of EGJ outflow obstruction also came out with this sort of clinical algorithm in their technical review, which really kind of simplifies this entire process, where you go down this algorithm and you may end up, if you do have an abnormal esophagram and or flip or pharmacologic provocation with this conclusive diagnosis, But if you don't end up all the way down there, you have an inconclusive diagnosis of outflow obstruction, and they even recommend saying, refrain from definitive therapy and consider repeat testing. Now, moving along, if you do not have an abnormal median IRP and you do have 100% failed peristalsis, you now have a diagnosis of absent contractility. And a conclusive diagnosis means that you have a normal median IRP in both positions and 100% failed peristalsis with a DCI less than 100. And typically, an example swallow will look like the image shown, where you're really not worried about an outflow obstruction down there. A lot of this is pattern recognition when you do more of this. And you're going to have that normal IRP and not a lot of activity there in the body. You may end up with an inconclusive diagnosis if you have a borderline median IRP, particularly in the Medtronic system of 10 to 15 in at least one position. And in those cases, you're going to consider type 1 achalasia. Now, I paired from the technical review that image there of the algorithm of sort of how to think about this, especially if you have an inconclusive diagnosis, and I leave you that for your reference. Now, going down the hierarchical classification scheme, so what happens if you don't have 100% failed peristalsis and you do have a normal IRP and you have at least 20% swallows with premature contractions? That would be distal esophageal spasm. However, the authors recommend to make a diagnosis of clinically relevant, conclusive distal esophageal spasm, you need both these 20% or more premature contractions with that distal latency less than 4.5 seconds and a sufficient DCI. And also you have to pair that with clinically relevant symptoms of dysphagia and or non-cardiac chest pain. Now you can see the paired algorithm from the technical review on the right. There is a mention there actually of contractile front velocity, so I felt obligated to mention that here. You may have an inconclusive manometric diagnosis if, let's say, you do have 20% or more premature contractions, however, the DCI is weak, or you have at least 20% where the distal latency is actually normal, but your velocity and that slope of peristalsis is almost vertical, typically with a velocity over 8 centimeters per second. And then moving along to hypercontractile esophagus. So hypercontractile swallows you heard about. So how do you make a diagnosis of clinically relevant, conclusive hypercontractile esophagus? You have at least 20% of these hypercontractile supine contractions with at least a DCI of over 8,000. You have clinically relevant symptoms, the same ones, dysphagia and or non-cardiac chest pain. And you may have three patterns, either single peak, you see there on the bottom left, repetitive, where that contraction is persisting, typically for more than 10 seconds, you see in the middle, or an LES after contraction, where you're actually looking at the DCI and including the LES when it has a rebound contraction after relaxation. Now, you may end up with inconclusive hypercontractile esophagus if you have 10% of your supine swallows over 8,000, or you have 5,000 to 8,000 DCI and symptoms of dysphagia or non-cardiac chest pain, and you see the associated clinical algorithm for your reference. All of these algorithms are a little outside the scope of my talk, which is not really about treatment, but I do think it's a relevant context to put all of this in. Now, the last disorder we're actually going to make is ineffective motility. Now, those of you who remember 3.0, it was a little easier to make this diagnosis on high-resolution manometry, because now to really make a conclusive diagnosis of IEM, you need greater than, not at least, 70% ineffective, meaning at least 80%, really, typically if you're doing 10 swallows, weak or failed by DCI or a greater than 5 centimeter break, or you need at least 50% failed with that DCI under 100. An inconclusive diagnosis of IEM means that you have 50 to 70% ineffective, but you don't meet the criteria of at least 50% failed. And you see the paired clinical algorithm here, which really talks about how to think about the inconclusive diagnoses and what really will strengthen you or not to think that this is a relevant ineffective motility. And then lastly, if you end up down here where you have no evidence of a disorder of peristalsis, if you do have a high probability, you think clinically, of missing an EGJ outflow obstruction, perhaps you do a solid test meal. You're going to hear about that. And in patients with primary regurgitation or belching, that really doesn't make a lot of sense clinically with their anatomy. Maybe you choose postprandial high-resolution manometry monitoring with impedance. And having the impedance sensors really means you can look at air and liquid movement. And if you catch the patient having their belching or regurgitation, you can really assess for whether or not this is rumination or it's a belching behavioral disorder. And with that, I'd like to thank our team at NYU that really helps put this all together, and thank you all for listening.
Thanks very much, Dr. Khan. So in the next series, we're going to be discussing provocative maneuvers and how they're used. First up is Diana Snyder from Mayo, and she is an assistant professor of medicine there. Diana?
Thanks to the course directors for inviting me to present. So I think we already learned the most important thing about MRS is that Dr. Rogers lacks reserve. So I'll let you interpret at you will my presentation. So as discussed, I'm going to be talking about the multiple rapid swallow sequence. So first I'll be defining the protocol in the setting of the updated Chicago Classification 4 guidelines, and then discuss several clinical applications, initially talking about impaired inhibitory pathways, mainly in opioid-induced esophageal dysfunction, as well as distal esophageal spasm, then talk about deficiency in the excitatory pathway, with the example being scleroderma, and finally, evaluation in the setting of anti-reflux surgery. So as you can see here, this is a normal multiple rapid swallow sequence. There's really two components to this. So it should be 5 rapid swallows at 2 milliliters of liquid, and this should occur every 2 to 3 seconds. As you can see, during the initial swallowing phase, there should be absent body contractility with a DCI less than 100, in addition to complete deglutative inhibition with relaxation of the LES. And then following the MRS swallows, there should be a post-contraction with peristalsis present, as well as augmentation. And we define the augmentation as a DCI that's greater than the mean DCI of 10 of the standard swallows. So first I'll talk about the inhibitory pathways. And just to remind everyone about opioid-induced esophageal dysfunction, so this is a clinical diagnosis that's based on symptomatology, including dysphagia, chest pain, reflux symptoms, in the setting of chronic opioid use, typically at least 3 months, in addition to manometric evidence. And the manometric evidence we see with this entity is distal esophageal spasm, esophagogastric outflow obstruction, achalasia type 3, or hypercontractile jackhammer esophagus. So what we were noticing here, you can see in the panel side by side, again, the normal MRS sequence, and we were noticing in our chronic opioid patients that they had impaired deglutative inhibition during the sequence. You can see the contractions going on during the swallows. So we decided to study this further in order to elucidate essentially the mechanisms behind OIED and what's actually causing this. So we hypothesized that the opioids are interfering with the nitric oxide relaxation pathway, leading to unopposed excitatory stimulation. So we evaluated 72 chronic opioid patients. We compared them to 100 non-opioid users, as well as to 24 asymptomatic healthy controls. And we find the chronic opioid users had a significantly higher rate of impaired deglutative inhibition during MRS at 54% compared to 14%, and none in the asymptomatic healthy controls. So as I mentioned, this supported our hypothesis that the opioids are interfering with the nitric oxide relaxation pathway, leading to this unopposed excitatory acetylcholine stimulation. So next I'll talk about distal esophageal spasm. So the mechanisms of distal esophageal spasm are not clearly defined, but we hypothesize again there's impairment in the inhibitory pathway leading to the premature contraction. So our team evaluated 19 patients with distal esophageal spasm and compared these to 24 asymptomatic healthy controls. And the distal esophageal spasm patients, actually 89% of them had impaired inhibition on MRS compared to none in the healthy controls. So as you can see on the panels on the right, first these are the single swallows. You can see the normal peristaltic progression in panel A. And then in panel B, distal esophageal spasm with a short distal latency of 3.3. And then on the right panel, C and D, normal again, multiple rapid swallow sequence, and then again, contractions going on where there should be complete deglutitive inhibition on the lower D panel. So now I'll talk about deficiencies in the excitatory pathway. The main study for this was done several years ago in conjunction between Mayo Clinic and Northwestern, evaluating 111 patients with scleroderma and determining the most common manometric findings. And of course, there were patients with absent contractility and hypotensive LES, which we would expect as one of the hallmarks of the scleroderma esophagus. But interestingly, the most common findings were actually the abnormalities with MRS post-contraction. So over 62% of the patients who had MRS done, there was absent contractility, and over 80% of patients that had a contraction did not have the augmentation, meaning the DCI ratio greater than 1 compared to the mean swallows. So finally, I'll talk about MRS in the setting of anti-reflux surgery. There were a couple studies done evaluating this and essentially trying to figure out, can MRS be a tool that can be used to determine peristaltic reserve in the esophagus and something that could predict postoperative dysphagia? So this was an evaluation of 63 patients who are undergoing Nissen fundoplication laparoscopically, and they evaluated the MRS sequence for these patients, and they found for the patients that never had dysphagia, 58% of them had a normal MRS, versus those who did have any form of dysphagia, only 14% had a normal MRS. In addition, delineating it further, they found that patients that have late postoperative dysphagia were most likely to have absent contractility post-MRS, suggesting lack of reserve. So in summary, the multiple rapid swallow sequence has been formally incorporated into the Chicago Classification 4.0. And this is really a tool to assess esophageal inhibitory as well as excitatory pathways. Incomplete deglutitive inhibition is more prevalent in patients with opioid-induced esophageal dysfunction as well as distal esophageal spasm. Also, abnormal augmentation or absent contraction post-MRS is prevalent in the scleroderma population. And finally, MRS may be one of the tools that can be used to predict postoperative dysphagia after anti-reflux surgery.
Thank you very much, Dr. Snyder. What Dr. Snyder doesn't know, actually, is that the MRS was the least of my concerns. I got very excited after I did my manometry. I sent the results over to Prakash. Prakash took a look. It turns out I have esophageal hypersensitivity, and I've actually been started. He's got me started on a neuromodulator. Prakash is going to have to start me on a neuromodulator soon, it turns out. So I've got bigger problems than my MRS. So also joining us remotely today is Dr. Adriana Lazarescu. She's an associate professor, of medicine at the University of Alberta in Edmonton, Canada.
Good morning. I would like to thank the organizers for inviting me to take part in this course and for the opportunity to present virtually given the pandemic situation. You have already heard about the multiple rapid swallows. I would like to discuss another manometric provocative maneuver, the rapid drink challenge. My objectives are to review how the rapid drink challenge is performed and to discuss the clinical utility of the RDC in the diagnosis of esophageal motility disorders. A few years ago, when the concept of provocative testing was being developed, we were mainly talking about multiple rapid swallows. However, there were various protocols with varying volumes of fluid used, anywhere from 10 cc's to 200 cc's. It then became clear that the information gathered from the larger volume RDC was similar but not identical to the smaller volume MRS. Before going further, let's take a moment to review the protocol for the Rapid Drink Challenge. The Chicago 4.0 standard esophageal manometry protocol begins in the supine position with the baseline measurement and 10 wet swallows, followed by one or more multiple rapid swallow sequences. The patient then sits upright, and after a period of adaptation, the second baseline is measured. 5 upright wet swallows are then performed. The Rapid Drink Challenge is the last part of the study. The patient is still sitting upright with legs hanging over the side of the bed. The patient will then drink 200 cc's of water through a straw as quickly as possible, then stop swallowing. If you are using impedance manometry, then a saline solution can be used instead to better highlight the impedance and measurement of bolus transit. During rapid drinking, the esophagus becomes a passive conduit. So when the Rapid Drink Challenge is performed, the expected response is absence of esophageal body contractility, meaning a DCI less than 100, as well as complete deglutative inhibition of the lower esophageal sphincter. With respect to the LES, the IRP should measure less than 12 millimeters of mercury over the first 30 seconds of the RDC. However, studies have shown that normal values for the IRP during the Rapid Drink Challenge may vary with different brands of software and manometry equipment. What you see listed here is for Medtronic. When there is structural or motor EG junction obstruction, you can encounter esophageal pressurization, shortening, or contraction. The presence of a normal peristaltic contraction sequence after the RDC is a specific marker of normal contractility. However, unlike with multiple rapid swallows, a normal contraction sequence following the RDC is not always present, even in healthy individuals. As a result, multiple rapid swallows are better at assessing peristaltic reserve, while conversely, the Rapid Drink Challenge provides a greater stress test for resistance to outflow in the esophagus. Here is an illustration of the intact response to Rapid Drink Challenge. At the top, you can see multiple swallows in quick succession at the level of the upper esophageal sphincter. Concurrently, the lower esophageal sphincter relaxes fully, and there is no contractility measurable in the esophageal body. In this particular instance, there actually is a normal peristaltic contraction following the RDC, but again, this does not always happen. Its absence does not imply abnormal esophageal motility. The Rapid Drink Challenge has been most useful in improving the diagnostic accuracy when latent EG junction outflow obstruction is suspected, but individual swallows are inconclusive for obstruction. As you know, EGJOO became part of the Chicago classification in the 3.0 version. At that time, all that was required for the diagnosis was an elevated mean IRP for the 10 supine wet swallows. It quickly became apparent that many patients who had this manometric finding had no obstructive symptoms nor any objective evidence of bolus retention. Many never progressed to achalasia or another motility disorder. In order to make the definition of EGJOO more robust and more clinically relevant, its diagnostic criteria was strengthened in the Chicago 4.0 version. Currently, in order to label a patient as having EGJOO, you need a manometric diagnosis, as well as clinically relevant symptoms such as dysphagia or chest pain, and objective evidence of obstruction on a timed barium esophagram and or on FLIP. In some cases, there is still some ambiguity in the manometric diagnosis of EGJOO. The Rapid Drink Challenge can provide supportive evidence for the diagnosis if outflow obstruction and esophageal pressurization are present. Here's such an example. Once again, you can see several swallows in quick succession at the level of the upper esophageal sphincter. Unlike in the prior example, there is evidence of panesophageal pressurization, as well as a non-relaxing lower esophageal sphincter. In this example, there is also esophageal shortening with a hyperpressive pattern following the RDC. If we were to add impedance to the manometry, it would likely show bolus retention associated with these manometric findings, providing further supportive evidence for the diagnosis of EGJOO. Studies have shown that in patients with EGJOO, panesophageal pressurization during the Rapid Drink Challenge is associated with more severe dysphagia. However, this does not point towards a specific cause of obstruction. Furthermore, the mean IRP during RDC appears to be the best manometric parameter to predict outflow obstruction on a timed barium esophagram. In conclusion, the Rapid Drink Challenge is an adjunctive provocative test usually performed at the end of a high-resolution esophageal manometry study. It is helpful to think of it as a stress test for lower esophageal sphincter relaxation and opening of the EG junction. The Rapid Drink Challenge can be used to strengthen the manometric diagnosis of EG junction outflow obstruction. Thank you for your attention. I look forward to questions and comments during the discussion session.
Okay, the next talk will be about the third of the provocative maneuvers, the solid test meal. And for this one, we have Dr. Walter Chan, who is an assistant professor of medicine in the Division of Gastroenterology and also the director of the Center for Gastrointestinal Motility at Harvard Medical School. Walter, thank you.
Thank you for the introduction. Thank you for the opportunity to talk today, and thank you for a great course so far. I'm going to talk a little bit about the solid test meal as part of provocative measures. First of all, I think the previous speakers have talked about there are some potential limitations with some of the traditional measures during manometry. First of all, it's a little less physiologic. How many of us actually lay supine while we swallow, right? And the second thing is patients may only report symptoms with taking solids and meals and not with liquids, so it might not detect some of the abnormalities. So several provocative measures have been developed as an adjunct to the standard measures, and the ones I'm going to focus on is some of the solid testing, solid meal testing that you might use. Previous studies have shown that bolus consistency may affect detection of abnormal esophageal function. And there are studies that have compared solid or viscous swallows to standard liquid swallows in healthy volunteers. And what was found was that with solid swallows, you tend to get a higher relaxation pressure, so higher IRP. There's generally a shorter transition zone on the peristalsis, so a smaller peristaltic break. You generally get a nicer peristalsis. You might have a slower contractile front velocity or a longer distal latency, and you generally get a more vigorous contraction, a higher DCI, and you generally often see a higher intrabolus pressure as a result as well because of the consistency. And different normative values have been developed for solid swallows and healthy controls. And many you can see here, it corresponds to what we just talked about. They generally have a higher IRP, generally higher DCI, and a smaller peristaltic break. What are the values of adding solid test swallows? In one of the studies, adding solid swallow protocol to liquid swallows alone led to an increase in diagnosis for IEM in about 15% of patients. In a different study, using applesauce or marshmallow swallows in the supine position suggested an alternative diagnosis in about 18% of patients. And interestingly, the majority of these are new diagnoses for EGJ outflow obstruction. And finally, solid swallows may also add to the diagnostic value in patients who come in with post-fundoplication dysphagia. This is one study actually that came out a few years ago looking at over 700 patients who had both the standard liquid swallows and the solid meal test. And what they found was that the solid meal test increases the diagnostic sensitivity for a lot of the major disorders on manometry. And specifically, EGJ outflow obstruction was the most commonly found in patients who came in with symptoms but had a normal standard wet swallow test. So you can see here, in the purple area, which is patients who have normal or minor findings on wet swallows, which is on the left-hand side, the vertical column, a lot of them have a new diagnosis of some major disorder, specifically EGJ outflow obstruction, on this solid meal test meal. If you look at the green area, on the other hand, if you have a normal or minor findings on a standard test meal, very few of them actually have abnormality on a standard wet swallow test. So it seems like the solid test meal does add to the value of standard motility manometry protocol. So when we conduct this test, what are some of the medium to use? In viscous swallows, you can think about using some viscous gel or yogurt or applesauce. For solid swallows, you can think about bread with butter, marshmallow, graham crackers, sometimes soft-boiled rice. Soft biscuits can be used, dumpling or cake. The key is that they should be about 1 to 2 cubic centimeters in size. For a solid test meal, it should be 200 grams is the standard, and you can use bread, you can use rice, pastry, and sometimes you can actually ask patients to bring in the culprit food if they think a specific food generally triggered the symptoms. And how do you actually do these single solid swallows? If you do single solid swallow tests, it should be 5 to 10 test swallows, at least 30 seconds apart. One thing that's different from the wet swallows is that a lot of times patients may require more than one pharyngeal swallow to get the solid bolus down. So sometimes they may require 2 pharyngeal swallows with each esophageal contraction. When you analyze them, you generally still use the standard metrics, but employing different normative values. So the values that you would consider, we'll talk about the IRP tends to be higher with solid swallows. The normative value, at least based on the Medtronic system, has been set to be 25 millimeter mercury. You should find effective esophageal contractions in at least 20% of swallows, and these effective contractions are defined by having a peristaltic break that's less than 3 centimeters, having a normal distal latency, and also having a DCI of at least 1,000. You notice that these numbers are slightly different from the wet swallows ones. What about doing a solid test meal? You may consider doing that if the findings are normal or inconclusive in the standard wet swallows. Generally, we talked about using a 200-gram meals, and in a normal adult, they should take about 20 to 30 pharyngeal swallows to complete the whole meal, and they should complete it within 8 minutes. Generally, you can ask symptoms to monitor symptoms during the test so that you can correlate the symptoms with the manometric finding. And one thing that's different is that in addition to abnormal manometry, slow eating is also considered abnormal during the test. So if the patient cannot finish their 200-gram test meal within 8 minutes, that's considered abnormal. And how do you analyze that? Again, we use the standard metrics. We basically count all the pharyngeal swallows and all the esophageal contractions needed to complete the whole meal. And what you should find is that in a normal individual, at least 20% of the pharyngeal swallows should be followed by an effective esophageal contractions. And the definition of this effective esophageal contractions is the same as what we talked about with the single solid swallows, which is peristaltic break less than 3 centimeters, a normal distal latency, and a DCI greater than 1,000. And you can also find some abnormal diagnosis based on the solid test meal alone as well. For example, you can diagnose IEM if they're greater than 80% of the pharyngeal swallows that's followed by an ineffective contractions or failed swallow. So if they have a large break or if they're low DCI in this instance. Or you can diagnose EGJ outflow obstruction if the IRP is greater than 25 in more than at least 2 swallows. If they have abnormal distal latency in at least 2 swallows during a solid test meal, you can diagnose DES. And hypercontractile esophagus is defined by high DCI in at least 2 swallows. And finally, we talk about slow eating being another abnormality associated with a solid test meal as well. And this is an example of how this may change diagnosis. This is a patient with dysphagia who had a normal wet swallow test, as you can see here. But during a solid test meal, you can see that there is these higher contractions and also an increase in IRP. And patients also reported dysphagia symptoms around the same time when you can see the higher IRP. So this is actually a patient that you can diagnose EGJ outflow obstruction based on the IRP of greater than 60 on the solid test meal, even though the wet swallows are normal. The last thing I'll talk about is this extended impedance manometry in a postprandial meal test. This is an extended study, usually between 30 to 90 minutes in duration, using a combined impedance manometry. We ask patients to take a solid food test meal, which may induce or diagnose some of the functional or behavioral disorders. The use of the impedance is to show these retrograde movement of interluminal bolus, so either air or liquid or even a content they just ingested, and it might help you diagnose supragastric belching, rumination, or volume reflux during the postprandial period. And one of the main ones we often use this for is to diagnose rumination syndrome. And this can be diagnosed on this postprandial meal test by identifying these R waves, which are these rapid sudden increases in intragastric pressure of at least 20 to 30 millimeter mercury during the postprandial period. And you will see retrograde movement of contents in the esophagus on impedance immediately after these R waves, which corresponds with what we think about physiologically with rumination, which is gastric contraction pushing up the gastric contents, causing rumination. And this is an example of a patient with rumination syndrome that we saw. And you can see here these R waves, rapid increases in intragastric pressure that is followed by this retrograde bolus movement. And this is a patient with rumination syndrome. So in summary, solid test swallow, solid test meal can increase the diagnostic yield for some peristaltic and outflow abnormalities, particularly EGJ outflow obstruction. Ingestion of a 200-gram solid test meal should be completed within 8 minutes. And a normal solid test meal should include at least 20% effective esophageal contractions and less than 2 swallows with an elevated IRP defined as 25 millimeter mercury. And an extended postprandial meal test on impedance manometry may help diagnose some functional disorders such as rumination syndrome. Thank you.
Thank you very much, Dr. Chan. Okay, well, first I think it's worth saying that we have encountered one of those things most rarely found in nature, the fact that a meeting like this is actually running on time. So we're fortunate in that, and we now have scheduled a 15-minute discussion section. If I could ask the presenters from this morning's sessions already, if you could come up to one of the 3 tables in front, if you wouldn't mind, for just a few minutes for this discussion. We don't have a panel table set up, so we'll have to do this either by speaking loud or passing around the microphone. And then also, if I could have our technical experts in the back, are you able to display the Zoom for the virtual presenters? Are you able to put that up on the screen for us? Oh, perfect. All right, great. Perfect. Looks like we have Drs. Lazarescu and Chen joining us virtually as well. So we have everybody, actually just about everybody, to to answer questions that anyone in the audience has for any one of our presenters from this morning. All right, we have a question. If you all don't mind coming just up to the microphones, that would be great.
Good morning. Thank you so much. Really informative. And just a quick background. I work in a small hospital, so I function as a GI and as a surgeon. My impression of Chicago classification 4.0 is some of the stuff is just kind of backward, where you do the manometry and then you do the endoflip. In my practice, I do HD, Bravo, endoflip, and then when I encounter abnormality, then I get the manometry, or I do the manometry. So what your thoughts about that? How can you have a fantastic technology, and instead of multiple tests, multiple presentation, multiple sedation, multiple endoscopy, you can do one-stop shop. You get the information that you want about the pathology, ulcer, hiatal hernia, health grade, pH study, esophageal manometry with the endoflip, and then if you have abnormality, then you do the manometry. Thank you.
I think that's a question that multiple of our presenters from this morning might be able to take a stab at. And if I'm understanding correctly, what you're asking is, why not just start with endoflip and only do manometry if you find something abnormal on that? Is that correct interpretation? Yeah, okay, great, thank you. So does anybody, any of our presenters from this morning like to address that and their thoughts about starting with endoflip? All right, I think Dr. Rogers is going to take that one. Thank you.
They've actually done some work. Some people will use sort of this upfront testing, and they've done cost-benefit analysis on this, and they found that, for where the suspicion is very low, you can rule out a lot of things right up front, and you can save some time. For example, in the escalation of PPI therapy, for example, the problem is that, at least in my practice, I would be doing a lot of extra testing on normal individuals. And so for me, especially when the suspicion is, I use high suspicion to guide my management there and do only, sort of do directed testing. And that seems to work out pretty well. It's mostly for the, cost benefit to sort of save the testing on individuals who may not need it, because if I get the normal evaluation right up front, then I don't progress past that point. And the other thing is as you said, you're going to need manometry anyway to sort of guide your management on those patients regardless. So either way, you're going to have to double back and do that. I think it's mostly cost-benefit analysis at this point, because you'll need it, if you find an abnormality, you're going to have to go back and do the manometry either way. Roger, I don't know if that's what you...
Yeah. So I have a confession to make. I actually don't use endoflip in my practice directly. I refer for it occasionally, but only as indicated by the new Chicago classification. I think it's a great question because you raise the point of, well, you can do it at the time of endoscopy. Virtually all of these patients are going to get endoscopy, and they probably ought to get it first overall, unless you're trying to do all of the workup in one relatively short period of time, fell swoop. But I think that's certainly a worthwhile question. And do we have any other, actually, even anyone from the audience, their thoughts about that?
I can say something about that. I mean, it's a tough question for a basics of manometry course, but I think for FLIP, and you'll probably hear a lot about this during the main session, a lot of the sort of plans for FLIP down the road, potentially with future directions, are to do indeed that for some clinical scenarios. I think what we know now is that the most powerful FLIP result is a normal result. So if you think about EGJ outflow obstruction and what FLIP tells you or not, if the patient has normal EGJ outflow on FLIP, it's, fits very well with Chicago 4.0. And then if there's a normal rack pattern on FLIP, there's high agreement with normal motility on manometry. So I think you run into a little bit of trouble if the patient's symptomatic and you have a normal FLIP, because then could you then be missing something that manometry is going to tell you? But if you're doing the flip purely for something like before anti-reflux surgery, and you see a normal flip result, potentially that takes away the need for manometry at this point.
Thank you. We have another question.
Yeah, Joel Richter from the University of South Florida. I want to thank the young people for a superb presentation. I've been doing this for a long time, obviously. Let me make one comment that we're not emphasizing about the motility study. All of us know this in the lab. The reason we can interpret a motility study well is if our nurse does a good job. So when you see this scenario that Raina talked about putting the tube down, or the modeling, putting the tube down, letting the patient settle down for a minute or two, then doing your LES measurement and all of that, that doesn't happen most of the time. Patients don't like catheters down, and in fact, an interesting observation we've had is that UES sphincter is really nice to watch because it is powerful in squeezing really hard, oftentimes early on in the study because they don't like the catheter, then it settles down. The other thing is when we put this idea together with the old water perfused catheters that took a long time and the patients didn't like it, we said let's do 10 swallows or so. And measure from the first swallow on. Actually, in reality now, one of the things I've kind of seen and we've talked about, and we don't write about though, in HRM, best to analyze actually from the last swallow to the first. Because what you've done is, if you've done it right, you've gotten the patient trained in all of that. So it's not really unusual if you really look at it. Those first 3 or 4 swallows look really weird, and then everything smooths out. So I don't think you necessarily have to use a rule of 10. I like to use maybe a rule of 15 until I kind of get things settled down, but that's kind of an old guy talking about. But I do think that motility is basically as good as the nurse is spending time. Second question for you all is, and I'd be interested in the audience, how many of you have impedance combined with your HRM catheter? Just raise your hand. So that's most of us. We do it. And one of the issues that we deal with is Chicago still wrestling what to do with impedance. And that'll probably be in the next session because I've been involved in 2, 3, and now 4. But I'd like to hear from the group. I have a lot of problems with the distal latency. It was an attempt by Chicago to use pressure measurements to imply peristalsis. So what do you do with an impedance swallow that is read as premature by the HRM, but the impedance is normal? And that becomes particularly important in diffuse esophageal spasm. When you read spasm, because I don't like to read spasm because there's not much I have to offer in spasm, but what do you do when you've got these premature contractions and you have normal bolus clearance? I'd like to hear from the young people, or the various labs, how they're playing that out.
Dr. Richter, thank you very much. Obviously a lot of experience and wisdom coming through there. And I'm going to say a couple things about your first question and comment, and invite any of our other speakers to talk about that as well, and then I will let them take over on the second one. So that the first one, with respect to the technical quality of the study and the importance of that, I couldn't agree more. I think that is extremely important, and I'm currently practicing in a situation where I actually read for 2 labs and with 2 different teams, one that's under my absolute 100% direct control and one that's less so. And the one that's under my direct control, I will say, I feel better about looking at the studies because I know that person, that nurse who's doing it, it is very thoughtful about it, and we get very high technical quality studies every time. The other one, it's a little more hit or miss, and I cannot agree more how important that is. One of the things that I think is important to do is to frequently have, if the nurse or technician, and they have to have some experience, I think, to do this, but if they have any question absolutely do more than 10 swallows. And usually we're looking at, in my lab, especially where I have a little more direct oversight, at least 12 in every single study. And, you know, you can read 12, you know, and you can get percentages from that. And we do that all the time if they all look reasonable. But if you see some with a bunch of gagging and so forth that happens, or double swallows, which are very, very common, and that can be a technical issue. Sometimes it's more a patient issue, but in any case, you can throw those out. You can delete them, and you know, and be left with 10 that you can feel more confident with. So I think that's an outstanding point. Any other questions or I'm sorry, not questions, rather comments from the other folks? Yes.
Just, wonderful points. However, we have to remember that it is not the 10 best swallows you find, but 10 clean swallows. I agree the patients who gag or double swallow.
Oh, yeah.
Excluded, but saying that do 15 swallows, 18 swallows and find the 10 best, that is not the right answer.
No, I agree with you, and I don't think that's that's definitely not what I'm saying. You know, I'm saying if you have some where there's clearly some technical challenge, throw them out. You know, and so that you still have enough to evaluate. If you've got 18 swallows and all of them are, you know, free of things like, you know, immediate double swallows and gagging, then analyze them all.
Okay, I just wanted to make sure we answer what Joel was talking about in the scenario with the distal latency and difference in bolus. I think that illustrating an important part is to also take into consideration the patient primary presenting symptoms. So if they come in with more perceptive symptoms like pain, and they have the abnormal distal latency suggesting spasm, but they have a normal bolus transit, then you might think more about whether or not that might be more related to the symptoms. If they came in more obstructive symptoms, they have a normal bolus transit, then it might be a little bit less relevant based on the dysphagia symptoms. So that's how I usually look at it. It's not, I think it's less so just based on the hard cutoff, but also taking into consideration what the main presenting complaint of patients are and how they correlate, which finding it correlates with more. So.
Our limitation right now that we have in our labs, all of our labs now, when we have impedance, is HRM has not included. 4 is beginning to include impedance in IEM. You know, we're beginning to add that. So we've got to keep that in mind that 5 will include impedance. And in my lab, I have a great reluctance. I won't make a diagnosis of DES on premature contractions if I have normal bolus clearance. And I'm using time-varying esophagram, you know, also correlate for obstruction. The definition, the old definition of DES that we wrote about in the 70s was intermittent simultaneous contractions. Now that word has gone away, and there's new term premature contractions, but it's meant to mean impaired bolus clearance. And that we have to just accept right now because DES is a non-starter for the patient because we don't have any treatment.
I think on the flip side, the other challenging scenario when it comes to that too, with the changes in terminology and definition, is we see these patients, I think Abe kind of alluded to, who have a normal distal latency, but you can actually see simultaneous contractions even though distal latency is normal. So by previous criteria, we would say that they have DES because of these simultaneous contractions, even though the distal latency is maybe just over 4.5 seconds. So, you know, we now call it inconclusive DES, maybe evolving into DES or achalasia, but I think those are also a challenging group that we see sometimes as well. That impedance may also help, I think.
Do we have any other comments on either of those two issues from any of the other presenters, or particularly our virtual presenters, Dr. Lazarescu, Dr. Chen? Well, let's move on then to another question.
Yes, hi. Thank you for this good course. So I'm looking for practical advice for implementing the different techniques in the Chicago classification, including the the different, swallows that we talked about. So I also have a directorship on one center and read for two other centers that I'm not involved completely. And we also have a lot of patients that we do that we don't see before, surgeons or other gastroenterologists order the studies. And as you said, it's all in the hands of the nurse who's operating, which sometimes can give you variable results. For instance, how important is it to do the swallows both in two different positions in the updated Chicago classification? We haven't really changed that in our center yet because we're having a hard time applying it practically. And second is any advice on which particular subset of patients to do the rapid challenge swallow or the solid test meal? Again, given into consideration that most of the time, you're not even seeing those patients either before or during the study, and you're not present while the study is being done to actually, directly interpret the results and make decisions on whether you should do another step or not.
I think those are some great and very important points, and I can completely and totally empathize with you on that and the challenges in incorporating what is, for some of us, a fundamentally new protocol. And the software hasn't caught up yet. It's close. There are ways to do it, but you really have to be, I won't say creative. In fact, I had a conversation with somebody for quite some time on Monday about this. But you do have to know what to do to modify that and then retrain folks and so on. So great questions. Any answers or discussion from our presenters? Unfortunately, we don't have Dr. Yadlapati on because I think she would probably be able to give us the most effective answers. Dr. Gyawali.
I can try and answer that. I think the key is to send your personnel who do procedures to courses like this, because each of those elements in the Chicago 4 helps you not do the wrong thing in a patient. So if you're diagnosing EGJ outflow obstruction from 10 swallows, that may not be real. It may just be related to catheter position. If that's the case, you sit the patient up, that abnormality goes away. You do a rapid drink challenge, that abnormality goes away. So it is important so that you don't do the wrong thing in the patient. You can't be treating somebody with an elevated IRP just in the supine position if esophageal body contractility is normal. It's meant for those fringes of abnormalities. If it's obviously Chicago Chicago 4.0 achalasia type 2, you don't need those extra maneuvers. But like the questioner asked, you don't see the patients beforehand. And unless your lab is well equipped or the personnel are well trained to stop the procedure when they recognize those abnormalities, that's just fine. That's what my lab does. If it looks like it's clear-cut achalasia, you don't trouble the patient anymore. But if you can't do that, then it's useful to do all these extra maneuvers just so that after the patient is left when you read the study, you don't end up with an inconclusive situation from the 10 swallows. So the best advice is what Joel talked about, Dr. Richter talked about, a well-educated operator. An operator who knows what they're doing, who understands some esophageal physiology, understands some of the diagnoses we are trying to make. I think that is the best way to get good studies.
Great, thank you very much for that. Next question. I think this will probably have to be our last question before the break.
Hi, good morning. This is Salah Sama from Kansas. Two brief questions about IRP and two examples. If you have a large hiatal hernia, that the catheter passes the LES but is stuck in the hernia sac, can you put your gastric marker in the hernia sac, or it has to be below the diaphragm? That's question number one. Question number two, not uncommonly you'd see the stomach is pretty pressurized, and when you put your gastric marker in that area, that I feel it affects your IRP measurement. So how do you go by that? Do you disregard that and you say, I don't believe the IRP here, and I'm going to move on to barium esophagram with tablet, with or without endoflip? Thank you.
Great questions, because that scenario is not uncommon, and actually it's very much related to the previous discussion about the technical quality of the study. Some technicians or nurses are better at getting that catheter past the full construct of the esophagogastric junction barrier than others, and so. Personally, you can't really redo the study in most cases, so the cat's already out of the bag, so you have to figure out what to do when you don't have a catheter that's traversed the LES. And typically, I'm probably going to get stoned up here for saying this, but typically what I do is if I know I don't have an adequate or appropriate gastric baseline, if I know it hasn't completely passed through the diaphragm, then what I will indicate is a qualitative assessment of the lower esophageal sphincter mechanism as I can see it, and indicate that there's been a technical problem in passing that catheter all the way down, and evaluate the peristalsis, as we ordinarily would. That's what I personally do. I would love to hear from some of the other panel members how they do that or how they deal with that. Clearly, they do exactly what I do.
Well, that's supported. That's actually supported. I mean, it depends on what again, it goes back to what the patient's symptoms are, but that's supported by evidence. The vast majority of patients who you can tell that they've got pressurization and you're not crossing the LES. I mean, but we will, the truth is when it's in question, it's not uncommon for us to go ahead and pass it endoscopically, especially if it's an outside provider and we want to make sure we know what's going on. It makes a big difference whether or not it's my patient versus someone else's patient, for sure. For the hernia situation, it also depends. A lot of those are pre-surgical evaluations, so often you can make a qualitative assessment of the, the LES when you're in a hernia sac.
Yeah. And full disclosure, I am a surgeon, so that's, for me, that works. And if you see peristalsis in a patient that you're putting your catheter down, they've got a perisophageal hernia. Well, they don't have achalasia. That's very important, so that, and that makes you feel better as a surgeon. And if they were to meet, let's say, the older definition of esophagogastric junction obstruction, then and you aren't able to really get the full evaluation, you're probably still going to do those other metrics anyway. You're really not going to be able to call it EGJ outflow obstruction because you're not going to get a reliable IRP. But that's usually not relevant in patients with perisophageal hiatal hernia, because you see it all the time. So, yeah, Prakash.
So gastric baseline in somebody with a hiatus hernia, if there is pressurization within the hiatus hernia, then your IRP will be falsely low. Okay, it will be falsely low. But if the hernia is big, then the hiatus is probably open. So the pressure within a large hernia probably reflects gastric pressure. So it's not a problem if you have a lot of space between where the lower esophageal sphincter is and the bottom of the tracing, whether you have traversed the diaphragm or not. It is a problem if the distance is very short. If the catheter has not adequately gone through into the stomach, you don't have 2 or 3 sensors. In that case, there are a couple of surrogate markers for obstruction. What you're really trying to rule out is obstruction. A couple of surrogate markers for obstruction. One is pressurization. So if you see pressurization between the contraction front and the level of the LES, that should give you pause and you need to get an upright barium or some other evaluation to make sure that there is no true obstruction. It might just mean that the esophagogastric junction is not straight, it is a little kinked. Sometimes you can sort that out by standing the patient up, or sitting the patient up. But if it's a large hernia, I wouldn't worry too much about where your gastric baseline is, because the hiatus is likely very open, and you'll have a decent representation of gastric pressure within the hernia.
Thank you very much. Okay, I think we're going to go ahead and go to our break. We're going to restart at 10:20, and Dr. Rogers had one thing he wanted to add as well.
As you guys walk out, do us a favor. This wouldn't be possible without the sponsors. They have booths set up out there. If you could please stop in, check in, and that would be much appreciated.
How are you?
Thanks, and see you all back in a few minutes.
Good. I've been well.